We are here today at the ASH 2019 meeting in Orlando with a lovely weather, very warm, and actually it's a very exciting meeting. Amazing novel multiple myeloma results. The field keeps on growing. This is really great news, lots of hope for patient, and hopefully outcome of multiple myeloma is improving. There are hundreds of myeloma communications at this meeting. However, I thought on a personal level that the immunotherapy of myeloma is moving in the right direction. We do have some nice CAR T-cell data. For instance, the CARTITUDE phase 1 protocol is clearly reproducing and further confirming the results of what we have seen using the same CAR T-cell construct directed against BCMA in the LEGEND-2 trial reported a couple of years ago with a very high response rate, a very good safety profile, very low incidence of CRS, and most importantly, many patients, 1/3 of the patients, are achieving deep negative MRD. So CAR T-cells are likely to become key players of multiple myeloma in the next couple of years or so, especially that these results were achieved in a cohort of patients who received a median of 5 lines of prior therapy, including monoclonal antibodies against CD38. Having said this, I believe the CAR T-cells are being now challenged more and more with the BiTE antibodies, the antibodies coupled to a Tcell Engager. We know this already from the ALL field with blinatumomab, but now in myeloma we had at this ASH 2019 meeting a very nice communication about the so-called CC whatever 69 product, novel product, T-cell engager against CD3 but also BCMA, and showing an amazing rate of objective response, again in patient who received a median of 5 lines of prior therapy. And obviously these BiTE antibodies are off the shelf, easy to use. The safety profile appears to be very good, no safety signal so far. The study that was reported was a dose-finding study, and of course at the lowest doses, under 6 milligram, no or very few responses were seen. However, we see all the responses, including stringent CR and negative MRD. So my best speculation for the near future is that these BiTE antibodies will make it hard and will compete with the CAR T-cells, although at some point we will need all of these tools. In terms of antibodies, we had in this meeting the reporting of a novel anti-CD38 antibody, so-called TAC-079, subcute, excellent safety profile, has been tested similar to daratumumab in the past in relapsed refractory multiple myeloma patient. Again, an impressive response rate, more than 65%, and this is very welcome, I would say, into the arena of multiple myeloma, having now more antibodies against CD38. First in line was daratumumab, which has achieved and is achieving excellent results. Cetuximab, thanks to the ICARIA trial, is now coming into the field in combination with pomalidomide and dexamethasone. However, the multiple myeloma field at ASH 2019 is not only about relapse and refractory myeloma. we can switch gears 180 degrees, and actually the focus of this meeting has been also on smoldering multiple myeloma, and especially high-risk smoldering multiple myeloma, and even high-risk MGUS, which is very special. And for instance, we had the update of the CESAR trial from Spain, which is a sort of a comprehensive full package of therapy with induction with KRD, carfilzomib, lendex, lenalidomide, dexamethasone, followed by auto-transplant, consolidation, maintenance, and this strategy is proving to be effective, and now with longer follow-up, the survival rate is very impressive, more than 95% at 2 years for these high-risk smoldering multiple myeloma. Of course, on the other side, we have all the data from the randomized trial already performed by ECOG and published in Journal of Clinical Oncology, looking into the role of lenalidomide alone or with dexamethasone. So the field of smoldering multiple myeloma is rapidly moving, and I wouldn't be surprised that in the near future we will be able to further refine the selection of these patients and start therapy for them early without waiting for organ damage. Frontline therapy, we have also some good news. We had the longer follow-up of the ALCYONE trial in the elderly multiple myeloma. This is a trial which compared daratumumab, VMP, bortezomib, melphalan, prednisone to the traditional standard of care, historical standard of care, VMP, bortezomib, melphalan, prednisone, and we do have now more and more mature data, and with longer follow-up, there is an overall survival advantage in favor of daratumumab and VMP. And this regimen, although we know that daratumumab lendex is also another excellent regimen for elderly myeloma, this regimen can continue to play an important role because melphalan is an important drug in multiple myeloma, relatively easy to use, highly effective, especially in the high-risk cytogenetics, and we know that this combination will be and can be used in many patients in addition to the other alternative now, daratumumab, lenalidomide, and dexamethasone. So as you can see, the field of multiple myeloma is really fascinating this year, like in all previous years, and we are fortunate that this is a united international effort fighting against multiple myeloma and hoping one day to get rid of this nasty disease.